So welcome to everyone who's joined our second webinar event. My name's Zoe, I'm Chief Executive of Healthwatch Bucks, and I'll be chairing this evening's event. We know that the past few months may well have been an anxious time for people who are waiting for an operation. You may have had a procedure postponed, or perhaps you're waiting to hear when you can have your planned surgery. At this time, it's important that patients and their relatives know how hospitals in Bucks are managing their waiting lists and how they're keeping patients safe during surgery. As such, we're really pleased to be hosting this event in conjunction with Buckinghamshire Healthcare NHS Trust. For those of you who haven't come across Healthwatch Bucks before, we're the independent champion of people using health and social care organisations in Buckinghamshire. Sorry, I've just lost my text here, sorry. We're the independent champion of people using health and care services. We're here to listen to you and work with the people that run your services to make them better. Our vision is that your experiences, ideas and opinions make a change for the better in health and social care in Buckinghamshire. We're joined this evening by 8 panellists, and I'll let them introduce themselves, starting with Mike.
Good evening to all. My name is Michael Tyler. I'm one of the plastic surgeons here in BHT, and I'm also the co-chair of the Division of Surgery and Critical Care. And next, we've got Dr. Neil Evans.
Good evening. I'm Neil Evans. I'm a consultant in pain medicine, and I'm the lead for chronic pain in the trust.
Thank you.
Jenny.
Hi, I'm Jenny Ricketts. I'm the Divisional Director for Surgery and Critical Care. Hello, everyone.
Leslie.
Hi, my name is Leslie Clifford. I'm Associate Director of Communications at the Trust. Thank you for joining this evening.
Asifa.
Hi, good evening. My name is Asifa Sheikh. I'm a consultant in ophthalmology, and I'm also the clinical lead for ophthalmology at the Trust. Thank you for giving me this opportunity to talk to you all, and thank you for joining.
And Jason.
Good evening, everybody. I'm Jason Foster. I'm the General Manager for Patient Access and Pain Management.
And Charlotte.
Good evening, everybody. I'm Charlotte Moss. I'm Head of Physiotherapy at BHT and Deputy AHP Lead, which is Allied Health Professions. Welcome.
Thank you. And is that everybody? Do we have Stuart yet?
I can't see Stuart
Okay.
Joining yet, Zoe.
So yeah. Stuart might join shortly.
So we also have one of the orthopaedic surgeons, Mr. Stuart Blagg, who is also the lead for the trauma and orthopaedic department, hopefully joining us a little bit later. Thank you.
Okay, thank you very much, everybody. So as well as the panellists, I can see that so far we have about 35 people who've joined us for this event this evening. We really hope you'll find it helpful. I'll shortly be handing back to Mike to give a presentation. This will be followed by a Q&A session, and I can see the questions coming through on the chat bar already. A few housekeeping points before we start. We're recording this event and it will be posted on our website in the next few days, along with a summary of the Q&A session. We'll also be publishing a short report about the event, but we'll make sure not to include any personal details in this. We'll anonymise questions that could identify anybody. As you may have noticed, we're running this event in webinar mode, so you'll not be able to turn your camera or microphone on, and we can't see or hear you, but hopefully you can see and hear us. Now I'd like to hand over to Mike, who is going to go through his presentation, Caring for Patients Who Need Surgery During this COVID-19 Pandemic. Thank you, Mike.
Zoe, thank you very much. So, as Zoe said, the focus of this Zoom meeting is all about how we care for patients who need surgery in this time. In order to paint a complete picture, I'd like to spend a couple of minutes just to give everybody an understanding of how surgery is delivered. Next slide, please. And so essentially, we need to order our patients in some manner. Next slide, please. And there's really two types of surgery, two ways that we can get to have surgery. The first is as an emergency, and obviously, not surprisingly, we call this emergency surgery. So these are patients who are admitted perhaps with acute appendicitis, or if you've broken a bone, then you're going to come in as an emergency. You're not going to go on any administrative list. We're going to perform your operation and hopefully get you better as soon as we possibly can. And then we have planned surgery. Now, planned surgery or non-emergency surgery, these are patients who the surgery can be fixed, planned to a set date and booked at a specific time and date. Next slide, please. And ideally, what we'd like to do is treat everybody as soon as we possibly can, but unfortunately, due to limitations that we have on theatre space and staff, we can't do that. So we need some form of list. And the key thing about when we book patients for planned surgery is that we make the decision to admit. That's patients go onto a list, and that becomes our waiting list. And within that waiting list, we will have patients who will need to have surgery relatively quickly, especially for perhaps conditions such as having cancer. And there will be other patients who are able to wait a little bit longer. So that a degree of prioritization takes place within that list. And obviously, all of these operations are important, but the key thing about this list is that it recognizes that the consequences of any delay differ between different conditions. Next slide, please. So effectively, it's important, because we have a list, to make sure that people waiting on the list have some degree of monitoring, some way of knowing that we are keeping tabs on how everybody is progressing. And there's two ways that we do that. We have patients with cancer and patients who don't have cancer. Now, the patients with cancer, they are monitored in a very specific manner, which is dictated to us by the NHS, and it's a very good way. And there's various target times that we are expected to achieve. For example, we expected to see patients within two weeks of us receiving the referral from the GP if it's a suspected cancer, and the aim is to try and treat people within 62 days from referral to treatment. So that's pretty set, and that has been set for many years. What about patients without cancer? Well, this depends a little bit on how urgent their operation is. And obviously for some patients, as I said, it needs to be done in a matter of weeks, and others, they can wait a little bit longer. But there is this accountability for reasonableness that the NHS sets, and they say it is reasonable to make sure that we try and treat 92% of our patients within 18 weeks, and also that all patients are treated within 52 weeks, i.e. 1 year. So that was the standard and the method that we use to keep an eye on how long people are waiting on our lists. Can we have the next slide, please? But all of that was put a little bit into jeopardy when we started to prepare for the first wave of this pandemic. And following national guidance, the majority of the planned surgery was stopped on the 23rd of March in this trust. Next slide, please. So, I mean, I suppose the first question for most people say was why was it stopped? Well, we had seen from both China and from Spain and from Italy that hospitals were being deluged with patients who had COVID disease. And COVID disease is a disease that gives you respiratory symptoms. And if you are short of breath, this is something that can't wait. So it was imperative that the NHS prepared to receive patients coming in, firstly to the medical wards and also to intensive care. And as the surgical division, because we've got a lot of anaesthetists in our division, we had to give a lot of our anaesthetists to the intensive care because they're obviously able to look after patients who are in intensive care. A lot of the junior doctors that help us deliver the surgery were also redeployed to go to the medical wards and also to the intensive care. there was a whole redeployment of how we all did our jobs, and also there was quite a bit of equipment that was moved from theatres to go to ITU. So this had a profound effect on our ability to deliver the normal levels of planned care that we are used to giving. Can we have the next slide, please? Can I have the next slide, please? Yeah. So basically, the impact on planned care is visually illustrated in this graph. To some degree, this graph is quite confusing. I don't think you really need to look too much at the terms, but if you have a look at the figures on the left-hand side of the graph, that's April to October of 2019. Each blue bar represents, if you like, the amount of planned elective surgery that we were able to deliver in any one month, and it's measured in sessions, but which is a measurement of operating time. And if you then have a look at the right-hand side of the graph, you can see that from April through to October of this year, the impact that the amount of elective or planned surgery that we've been able to give has been dramatically affected by those changes that we've made in the hospital. Can we have the next slide, please? So the first question you might want to ask is, well, what about emergency surgery? Was that affected? And the answer is no. I mean, it was really important that we kept the emergency surgery going, because obviously people still get appendicitis or break their hips during COVID pandemic, and it was really important that we carried on to treat these patients. And so we made every effort to keep the emergency surgery going at Stoke Mandeville as we could. The problem of operating, of running any operating theatre in the presence of a respiratory, a highly contagious respiratory virus are really multiple, and it means that the process of giving an anaesthetic and the process of operating on patients becomes really quite dangerous to the people that are performing those procedures, and therefore it's really important that we use a series of processes, especially dressing up and wearing the masks, the special masks that we have to use, and visors and all the equipment. And actually, this dramatically slowed down the rate with which we could deliver, firstly, elective, emergency surgery. So all the safety precautions meant that any operation we did took it took about twice as long in theatre, in terms of theatre time, as we would expect. Next slide, please. And so that doesn't help when you're stopping elective planned surgery, and a lot of people were impacted. So at the start of March, we had just over 7,500 people who were on our planned list. And so what we decided to do was that we were going to treat everybody who needed emergency surgery. And then we went through that list and we looked at everybody who urgently needed surgery. So these tended to obviously be the patients who had cancer and various other conditions which were urgent, patients who were imminent threat of perhaps losing sight or having kidney damage or something like this. And we used a criteria, and the criteria that we're now using, next slide please, is one that is approved by the Royal College of Surgeons and is now one that we're expected by the NHS to apply to all of the patients who are on our list. And it's relatively straightforward, as you might imagine. P1s, or priority 1 patients, are those that need surgery within 72 hours. So these are effectively the emergency surgery patients. P2 patients are those that need to be treated within a month. P3 are those that need to be treated within 3 months. And a lot of our cancer patients will be in the P3. And then we've got a group of patients who are in P4. This means that they are able to wait longer than 3 months. Clearly, it's important that they have their operation, but the decay, the consequence of waiting more than 3 months are not going to be as dramatic as those in the other P3, P2, and P1 categories. And obviously the target remains as to that nobody waited longer than 52 weeks. Next slide, please. So that was the process of what we did with our list at the beginning of March. And the next thing we had to do when once we'd worked out who was on our list and how we might do, who needed surgery, we had to make it safe for them to coming into hospital. So the question is, how do we make it safe for somebody coming for an operation in the first wave? Next slide, please. And we kind of knew that it was vital that no patient caught COVID in hospital while they had the surgery. Back in March and April, there were some papers that were coming out from China and also from Italy, which demonstrated that if people had an operation just when they had COVID, that it made the operation more dangerous, and therefore we had to make every effort to stop people coming to hospital just when they had COVID, or indeed catching COVID once they're in hospital. So the government had a program of using the private sector, and we were very lucky in so much that the BMI Chiltern Hospital, which is in Great Missenden, we were able to use that. They have 3 theatres, and they weren't treating any patients who had COVID-19 because they weren't admitting any medical patients, and that hospital allowed us to keep some of our cancer services running almost normally, especially the breast cancer, and also our skin cancer service, and we're extremely grateful that we're able to use that facility. And in total, from April to September, we treated 921 patients in their operating theatres, and we treated a few people in the minor operations room as well. Next slide, please. So that was then. And what are we doing now to make sure we reduce our waiting lists as quickly as possible, whilst keeping patients safe? Because COVID, as you are obviously aware, certainly hasn't gone away. Next slide, please. I mean, in short, we're doing as much operating as we safely can. We've now reopened 10 of our theatres for low-risk patients. We still have the emergency theatres running, obviously, and this includes 2 theatres from BMI Shelburne, which is the private hospital just on the Wickham site. And again, we're really grateful to be able to use those theatres. We're increasing the number of operations that we're doing in all of the surgical specialties. We've made some special efforts in tackling 2 specialties, both ophthalmology and orthopedics, principally because these specialties represents the lion's share of people that are sitting on our waiting list. And we're in a process of setting up a mobile operating theatre at Stoke Mandeville, which over the year should enable us to perform an additional 4,000 cataract operations. Also, we're planning to do a big push, an extra effort from January to March to significantly increase the number of joint replacements that we're doing. Can we have the next slide, please? So the other thing that we've got to do is kind of re-look at our list. Now, we did this obviously in March, but that was a few months ago. So it's important that we have another look at our list to make sure that nobody has significantly changed, and that we are currently right in the middle of a process of reassessing all of the patients on our waiting list. Any patient who has cancer will be on that cancer pathway, and so they're going to be monitored through that. And all other patients, we're going to give them that prioritization category, that P category that we mentioned earlier. And that is a process that we want to be consensual. So we're writing to all of those patients who are in P4 and asking them whether they're comfortable to be in that category or if anything has changed. Those are patients who can wait for more than 3 months. And we'll be in contact with all other patients who have not had a date for surgery. Obviously, if you had a date for surgery, then we will not be in contact with you because we'll be assuming you'll be coming in for your surgery. Next slide, please. Our main priority is to keep patients safe if they come in for surgery. Obviously, that's extremely important. There's no point in doing surgery if it's not safe. So before we resumed the planned surgery, we did some pretty extensive risk assessment of where we were going to operate and where patients were, the wards that patients were going to recover from, and we designated some areas which were low risk areas. These were areas that were not going to have any COVID patients anywhere in the region. We're certainly not going to mix any staff who are working in the COVID areas to then come and work in the green areas, and the most important element is that that strict protocols around the use of personal protective equipment, or PPE as it's commonly known, and these processes are designed to prevent anyone catching or indeed transmitting COVID-19. And the other thing, in order to try and make sure that patients are not in the early stages of COVID infection just before their surgery, we ask patients to take special precautions for 2 weeks before their planned surgery. Next slide, please. So what are those special precautions? We ask patients to comprehensively socially distance for 2 weeks before surgery. So that's a phrase that probably needs a little bit of explanation. Effectively, what we're asking you to do is to keep your distance from people outside your household or support bubble, keeping your hands and face as clean as possible, keeping indoor places well ventilated, avoiding crowded spaces, working from home if you can, wearing face coverings at all times on public transport in enclosed spaces such as shops or banks, or visiting hospital, and washing your clothes regularly. And we then ask everybody to have a COVID-19 test 72 hours before surgery, and after that test we ask you to self-isolate together with members of your household until your surgery takes place. And so that is the program. Can we have the next slide, please? So I think that sort of gives you a snapshot of how we are caring for patients, and I just wanted to say that and to thank you for your understanding and patience with the changes that we're having to make. I certainly, and we all certainly appreciate that this is potentially stressful and frightening time if you are due to have surgery. I really want to assure you that we are doing everything we can to keep you as safe as you can when you come in to have your surgery. And so if you do have an appointment for surgery, please do come if you're offered one. Next slide, please. Thank you.
Thank you, Mike. I believe Stuart's joined us as well. So I don't know, Stuart, if you could just quickly introduce yourself before we go on to the Q&As.
Evening, my apologies. I'm Stuart Blagg. I'm the clinical lead for trauma and orthopaedics in Bucks Trust and a spine surgeon. Thank you very much for giving me the opportunity to talk about where orthopaedics is, and certainly orthopaedics is under quite a lot of pressure at the moment. So thank you very much.
Thanks, Stuart. So we're going to move on to our Q&A session. This is your opportunity to ask the panelists any questions you may have. We might not be able to get through them all, but any that we aren't able to cover tonight, we'll ask the panelists to answer them after the event, and we'll be posting the answers on our website. Please, can you type your questions using the chat bar function? If you could use the all panelists and attendees option, then everyone else will be able to see your question as well. Just a reminder that speakers can't give individual clinical advice, so please don't share any personal details, and remember that your name will appear in the chat bar. Please modify this if you'd prefer to be anonymous. We're going to start off with some questions that were sent in prior to tonight's event. And the first one is from someone who is asking, I'm waiting on an ultrasound guided injection in my foot. Are these going ahead? Sure, who's going to take that one?
So Jason, can I ask you to take that question?
Neil's going to take it.
Okay, sorry, Neil.
Thank you for that question. This is really for the division of radiology, but I spoke to the clinical lead of radiology today about this, and the short answer is they're resuming most of their injection activity at present. But ultrasound specifically, there is a slight delay and they're only at 2/3 capacity. And the reason for this is that they've been inundated with a lot of diagnostic ultrasound. And as Mike was alluding to earlier, this is done on clinical prioritization, and the prioritization goes to the patients that may have a potential cancer diagnosis. So the ultrasound injections are happening, but there will be a slight delay on capacity because of other issues.
Okay, thank you. So the next question is from someone who wasn't able to come along tonight, but is keen to understand the status of waiting lists for oral surgery. Their question is, my daughter was due to have a lump removed from her lower lip in March of this year. Obviously the surgery was cancelled. We've since received a note to say that we will be sent further news soon, but nothing further to date. As we have no idea what's causing the lump, we're obviously keen to have it removed as soon as possible. Any information that can be provided on when we might expect to hear further news or an appointment would be greatly appreciated.
So I can answer that question. We don't have anybody from the oral maxillofacial department on the panel here. But what we're doing at the minute, we're reprioritizing everybody that's on the waiting list. So we're going through everybody again and having a little look. You hopefully will have received the initial letter, which was sent to everybody, advising you that we're going to do this process. And then we're sending out another a letter to people who are designated as in that P4 category, and suggesting, asking patients if they're comfortable with that. If they're not comfortable with that, we're giving patients the opportunity of telephoning us and a process of us having a look at that. All other patients who are not in the P4 category, if you're P3, in other words, you have to be treated within 3 months, and we've designated that already, will be receiving a telephone call. The only other issue that I would say is that if you have any immediate concerns, in other words, there's been a dramatic change in the situation since you were last seen, that you get in contact with the department to articulate those changes which have occurred, because I'm sure they'd like to know if it's suddenly doubled in size or something like that. It'd be very important that you contact them, the department, and hopefully you should have some communication from the department. So thank you for that. And the other thing I would just like to point out is that you know, that the hospital obviously works very, very closely with the whole healthcare system. So that's your general practitioner and the wider healthcare system that we have in Bucks. So you know, your general practitioner is also a key element of this team in trying to get people treated, and so you know, just to point out that a community and general practice is also part of this team. Thank you.
Okay, thank you, Mike. So the next question is, we are registered Bucks residents, but my son is waiting for cranioplasty surgery at the John Radcliffe. Can you tell us anything about surgery outside the county?
So Jenny, would you like to take this question?
Yeah, no problem. Hi. Well, unfortunately, we're only covering Bucks patients in this seminar, but I can just reassure you that we work really closely as a system, which includes working with Oxford and with Reading. And what we're looking at is how we can share the activity out across the system by close collaboration. So unfortunately, in the direct answer to that is, I'm afraid, no, we aren't covering the waiting list at Oxford, but I would suggest that they contact the department to find out that information. Thank you.
Okay, thanks, Jenny. So the next question, I'd like information about realistic waiting times for those waiting for a hip replacement who have been funded by the NHS but occurring at the Chilterns. My mother had originally been informed of a likely operation date in November, but it's now after Christmas. Would be grateful for some information about how NHS lists of private hospitals are being managed.
And Stuart, can I ask you to answer that question, please?
Yeah, most certainly. So slightly difficult in that with Bucks Hospital, we can only really talk to you about the NHS work that's been commissioned through Bucks Hospital. And whilst we were working at Chiltern for a period of time, this hip replacement will be being done by a commissioning method that goes directly through to the Chiltern Hospital. So what I can't tell you is what that waiting time is. The Chiltern would have to do that. And the Chiltern will have a direct commissioning from the local commissioning group, and they will be managing that. I know they are doing these sorts of operations now, but exactly their waiting time, I wouldn't be able to tell you, I'm afraid.
Okay, thank you. So the next question, if there will be significant delay to elective surgery, how can other services for analgesia and pain relief be accessed other than through GP and prescription medication?
Yes, and thank you for that question. So we've got two people who I'm going to ask to speak on this, if that's all right. Neil, who's obviously a consultant pain specialist, and then Charlotte, also with regards to physiotherapy and other adjuncts to that. Thank you. Neil.
Thank you for that question. It's a very commonly asked question and a common problem. The delay for surgery, which happens before the COVID crisis, also meant that we were able to give advice to GPs and individual patients on other forms of treatment. I answered a question earlier about ultrasound or image-guided injections. So sometimes we'll use injection treatments to try and reduce pain whilst waiting for surgery. We use medication quite commonly. We have a nerve pain pathway that is written down for GPs to access, which is published. A lot of the ways that we will treat pain will be with medication, and that can be guided through the GPs, but the GPs can also get in touch with us and we'll answer any individual queries that they have to target bespoke treatments for patients. And of course, there's always the option of being referred to the pain clinic for an individual assessment if the delay is going to be significant.
And Charlotte?
Thank you. Obviously, there's pain is and the management of your symptoms of pain is a combination. So not only with your medication, but also enabling yourselves to keep as active as is possible. If you could do a little bit of movement or some exercise, then generally that will help. You don't want to be pushing yourselves into more pain, but as humans, we are designed to move, so generally the body will respond better to moving, and depending on your particulars, then there might be some subset of very simple things that you can do that will make a big difference whilst you're waiting. There are some useful websites that people can go for very generalised advice. Some of the Rheumatology Association websites are very useful, and the Chartered Society of Physiotherapy website can be very useful.
Okay. And we'll put the link to those in our transcript later. Thank you, Charlotte. So those are the end of our questions that were sent in prior to the event, and I'm going to go to the questions in the chat bar now. And the first of which is in relation to hand surgery. We have an attendee who has been waiting for a year to have an operation. Can you advise her?
Stuart, can I ask you to have a look at that question?
So at the beginning of COVID, we had quite a significant waiting list. And when we went into COVID, we've had to prioritise, and things like cancer obviously take higher priority than some of the orthopedic procedures, such as hand surgery. In the meantime, and over the summer, we've been looking at ways we can get ahead with this. The specifics I can't really comment about, but we have been making an enormous amount of progress on our waiting list, and the hand surgery waiting list is one that is getting much better under control, which I know is not ideal, and it's not a position that any of us want to be in. I can't give you a time, but certainly we are aiming over the next 3 months, 4 months to get the hand surgery waiting list to the point where we are back to a reasonable point. And that's not very exact. There's a lot of things we're trying to do. I can't give you a perfect time for this, I'm afraid.
Okay, thank you, Stuart. The next question, and I think you touched on this in your presentation, Neil, sorry, Mike, do you guys know when ophthalmology surgery will recommence, as we were due to have a procedure at the end of March?
Well, we've got the perfect person to answer this question, Asifa, and perhaps you can answer this question. Maybe the audience would like to hear a little bit about the big push that we'll be doing on cataracts as well. Asifa, thank you.
Hi, good evening. Thank you for the question. So you haven't mentioned what sort of ophthalmology surgery you were due to have. There's many different types of ophthalmology operations. The commonest operation we do is a cataract operation to restore someone's vision. In fact, 50% of all the operations we do is for cataract, but there are lots of other eye conditions which require surgery. So if I can just sort of give you a general answer, the number of waiting patients on the ophthalmology waiting list pre-COVID were roughly 4,000, and 50% of those patients are people waiting to have cataract surgery. In fact, we were one of the first departments in the country to restart local anesthetic cataract surgery back in May this year. This was following a review of our pathways. We did a walk around of facilities, and our pathways were considered to be safe for patients to come in and have surgery. So as I said, we started local anesthetic cataract surgery back in May of this year. And to date, we've done, I think, nearly 1,400 procedures, that is cataract. If it was a non-cataract operation you were due to have, then we restarted those operations in August. A lot of those operations required general anesthetic, so we had to ensure that it was safe for patients to come in and have their operations done under general anesthetic. As Stuart alluded to earlier on, these operations are now taking much longer than they used to pre-COVID. So the numbers going through are smaller than they used to pre-COVID, because we have to take all the special precautions before patients come in and also during the operation. So generally our theaters tend to run at 50% capacity for non-cataract operations. With cataract itself, we're making lots of measures. In fact, we are also one of the first departments in the country to do this, to try and help patients and help our waiting list. In the last 2 weeks, we've been doing a cataract blitz, which means that we've stopped all other operations and we're running high volume cataract lists in order to obviously help patients who've been waiting a long time. And in 2 weeks, we've done nearly 430 cataracts. Again, as Mike alluded to, we've taken charge of a mobile cataract unit, which kicks off actually next week. And all being well, we hope to be able to do 4,000 cataracts in a year in this mobile unit, in addition to the cataracts we do in our existing theatre suite. So we're hoping to help patients as best as we can and as quickly as we can. The non-cataract patients, we're going through our waiting lists. We're doing those patients, we're prioritizing patients based on their risk of visual loss. So high-risk patients are being done first. And we'll get to everyone hopefully soon. I hope that answers your question.
Thank you for that. So the next question in the chat bar is from someone who was told in February that their meniscus tear, hope I pronounced that right, needed urgent repair. Is there any way I can be seen again in clinic, as my leg is almost permanently swollen now, including my ankle? The most recent letter I had said I may have to wait another 52 weeks at least for surgery. Don't know if anyone wants to take that.
So I think we can answer that. I'll talk a little bit about the prioritization process, and then if you're comfortable, I'll ask Stuart just to answer that as well. As the letter says, and as I mentioned in the talk, we're now in the process of reprioritizing really everybody who's on our list. It's logistically a lot of work, and we're starting this process. We've written to everybody, and I suspect, I'm not sure if the letter came from the prioritization team or direct from the department, we are sending out a second letter for those patients who are in the P40 category. And as I mentioned, we are asking patients if they'd like to, if they have a problem, to contact us. So that's in the wider sense that we're doing. Within the specifics of this, I think if situations are changing, and the situation from when you were originally seen is different from what it is now, then it's always worth trying to getting in contact with the original department with whom you've got your operation booked, because there may be a change that requires a change in tactic. And Stuart, maybe you'd like to add something to that as well, please.
So Mike, thank you very much. I think that's a pretty good summary. What you'll have been told in February was in good faith, and the surgeon didn't know what was going to happen in March. We've had to reprioritise, and we've had a reduced ability to do things. But certainly if the priority has changed, if your clinical situation has changed, we need to hear about it. And unless we hear, we don't know. But if we hear, we have the ability to adjust. And certainly surgery is going ahead at the moment. It's just that we do have to prioritise, and we have a reduced capacity. So please do get in contact with your surgeon, let them know if the situation's changed, and hopefully that will lead to a reprioritisation. I hope that answers that. Thank you.
Thank you, Stuart. And the next question that we have is around capacity. So planned surgery list indicates a capacity issue. In normal times, is this capacity reached for theatre time or staff resource first? And how does this capacity look over a normal year?
So yes, it's normally a fairly balanced and actually finely honed and efficient process. But I think probably the best person to answer this is Jennifer. Jennifer, if you're comfortable.
No, that's fine. So as you alluded to in your sort of presentation, we are back up and running now on all of our theatres. It's a mixture, really. It's not as clear cut as theatre time or staff resource. It is a mixture of both, and it's a sort of a fine line between how much staff we've got available. We work really hard on increasing our productivity and the utilisation of our theatre time, and certainly it's our most precious resource that we have. So we do our very best to optimise the time that we have within it, So last year we increased our productivity by 7%. We were one of the only trusts in the region that were able to do this and sustain this. So we are taking it very seriously. And the last question: how does your capacity look over a normal year? The population is growing. We would of course like more theatres, but again we have to be able to staff those theatres, and we are within a sort of we only have the facilities that we do have. So again, sorry, it comes back to utilising and managing that theatre time in the best way possible.
And if I can add, I think in a normal year we would expect our cancer time cancer treatment figures, in other words, those time figures that I mentioned earlier on in the talk, we would expect to be adhering essentially to those. And likewise, you know, on for the planned patients, the non-cancer patients, our performance in terms of the treating patients within 18 weeks and our 52-week breaches were really very low. So in a normal year, things were running relatively smoothly. As you saw from the graph I showed you, of our, where you saw how much of our planned surgery has been removed, there's this big bulge of patients that we're desperately working, well, we're working very hard to try and get through, and that's obviously meaning that this year is not normal in terms of those waiting times.
Okay, thank you. Next question. For deprioritised patients, are there opportunities for non-surgical action to minimise the detrimental effect of delay?
Charlotte, it's back to you. Can I ask you to answer that again, please?
So yes, it's a generalised question. Obviously, it depends what type of surgery that you're waiting for. One thing that we have seen nationally during this pandemic is not only the delays caused where people are not having the surgery they want, but generally speaking, the population, sadly, particularly those that have become needed to shield first time round or have not regain their confidence of going back to their normal activities before we got to our current status, then we are noticing a deconditioning that has happened, and that then has a knock-on effect in all sorts of other ways. So again, in general terms, trying to maintain activity. I know there's a question that's come up further down the list where this might be touched on later, but if you're maintaining the range, which means your how much a joint can move, and also trying to maintain some muscle strength. So even just very simple things of walking around inside, if the weather is inclement, walking around inside for regular 3 minutes continuously, if that's quite difficult for you because of pain or because of your ability to tolerate that, if you just do that every other day and then the following week maybe increase that to 3 minutes every day, then over time that will increase. There is quite a bit that can be done. It may not always replace the surgical need, but it will certainly also help to keep you optimized so you're then as fit as is possible for when you do get your surgery, and that will help your recovery and make your recovery from surgery much quicker too.
Okay, thank you, Charlotte. Okay, are the special precautions applied to all sorts of surgeries? For example, to GA, I think that might be general anaesthetic dental surgery patients? Taking a guess here.
No, quite right. Absolutely. Yes, I can answer that one. The special precautions are applied to all sorts of surgeries, especially under general anaesthetic surgery. So yes, if you're having a general anaesthetic, you will need to do the 2 weeks of taking a great deal of care with that enhanced social distancing, and then have the COVID swab, and then from the COVID swab to your surgery, we'd ask you to self-isolate. Yeah.
Okay, thank you. So next question. My son is awaiting on a squint corrective surgery. Are these going ahead?
That's
Hi, good evening again. So yes, we've been doing squint operations since late May. Aside from cataract surgery, that was the other operation we started really quite early, as we felt that the risk to children coming into hospital and having a general anesthetic was quite small from COVID. So the child was swabbed and the accompanying parent was swabbed, and we've been doing these operations, as I said, since late May. As I said earlier, the numbers of operations we're doing on each available list is smaller than we were doing pre-COVID because of all the special precautions that we have to take for these patients, the donning and the doffing. And so there's a lot of turnover time in theatre because the patients have to be recovered in a safe manner before the next patient is brought in. Long-winded answer to your question, these operations have been going on since May. The operations are being prioritized in the sense that children who have risk of visual loss are being done as a priority, but your child should receive a date in the not too distant future. We have two consultants specializing in pediatric ophthalmology, you know, they're doing these operations as quickly as they can.
Thank you. Okay, next question. When does the 52-week clock start? From when you were first referred for surgery, or from when you were reassessed the priority of each patient? Thank you.
Jason, is that a question you feel comfortable answering?
I'm happy to take that one.
Okay, I think Jason's, I think it's frozen. Yeah, sorry.
Frozen. No problem. No, it is from the, your 52-week clock starts from the moment you're referred for surgery.
Okay. Thank you. And could someone explain what donning and doffing is for me and our attendees? Thank you.
Let me see. Yes, so donning, I can answer that. Donning is when we put on the personal protective equipment. And COVID is a highly infectious disease, and we catch it from the little bits of spittle if we're talking or sneezing or whatever it is, or coughing, and those bits of spit arrive. Sorry to be a bit agricultural with this. Those bits of spit arrive and they dry, and those little dried bits of spit are called fomites, and fomites then contaminate areas. And so basically what we do is we put on goggles, we put on our mask, and then we put on a gown to stop us. So if you and depending on the situation we're in, it will depend on how big our gown is, what sort of mask we have to wear, and so we have to don that. And we have to do that in a very special order, because it's really important that we take it off in the right order. And when we started training this, we were telling people, imagine that someone smears you with a whole load of manure. You're going to take it off in a way that you don't want any of that manure to contaminate your clothes, if you see what I mean. So that's why taking it off in a very special order. So donning is the putting it on, and it's a very special and synchronized activity that you do. And then we often have a buddy that looks and checks that you're doing it correct. And then the doffing is the taking off of that PPE, again in the correct order, to make sure that you take it off and you put the contaminated material straight in the bin, and don't leave it lying around and everything. So so donning and doffing, it really refers to the discipline of putting on and taking off the personal protective equipment.
Okay, thank you, Mike.
Like a dance.
That explanation. So the next question, my GP has referred me for a hip replacement, but I've not heard anything yet. Can I assume I'm on a list?
Stuart, can I ask? Or Jason?
I can answer that up to a point, and then I'll ask Jason possibly to add some more information to it. So we've talked about waiting lists, and a waiting list starts for surgery when a patient has been put on the waiting list by one of the consultants or their team. So after referral, you're not necessarily on a waiting list for an operation. You need to be seen by the team. The waiting lists are what we've mostly talked about already. Once the referral has been made, that referral then needs to be allocated an appointment, and exactly how that works, probably Jason's the best person to explain that. Jason's in charge of that department and can give you some idea of the process between the referral and meeting a consultant. Is that okay, Jason?
That's okay, Stuart. Thank you, everybody. Similar to operations, we've had to prioritise outpatient appointments as well. And when COVID commenced, there was a delay. We had to stop our outpatient practice in a lot of areas. So new referrals are delayed in certain specialties, and we're trying to get them back up and running. Some of the areas are still not looking at routines, but we're doing them in order back from when referrals received during the COVID time at the beginning. But we are prioritising urgents, cancers, etc. With regards to orthopaedics, we're still trying to get through the new referrals and get them into clinic. Now the clinics are up and running.
Okay, thank you. Okay, I think we've got time for a couple of more questions before we do our closing remarks. We will make sure any questions that haven't been answered in this session are picked up afterwards. So how long do you recommend to isolate if having open myomectomy, this is challenging me today, due to COVID-19? Does the 2-week isolation prior to surgery apply to all surgeries? Who would like to take that?
Yeah, I can do that one. Again, the 2-week does apply. An open myomectomy it's an elective procedure, so therefore we need to make sure it's safe. So we would be asking you to apply to that 2-week. Now, there's a slight difference between self-isolation and enhanced social distancing. And if I can give you a little bit of history on that, in the summer, when Public Health England, which is the body which advises us on how to do these things, advises us how to keep patients safe, they initially ask everybody who's having an operation to self-isolate. That means stay at home and don't go out for 2 weeks. And obviously a lot of people found that very, very difficult. And there's also a sense that actually that was taking it too far and making it too difficult for patients. And therefore they then gave us some revised guidelines, which are the ones that I gave you in that talk. And that basically means that they want you to have this enhanced social distancing. So you can still go out, but make sure you follow the rules really carefully. As I said, make sure you keep your distancing, make sure you wear your mask, make sure you wash your hands, make sure you keep your clothes. So do those things and then have your test. And then you only have to self-isolate from your test to the surgery. So, but it still means that special effort for 2 weeks before your surgery. Thank you.
Okay, thank you. Okay, if we could take one more question. There might be a gap between your confidence about delaying surgery and the patient's confidence about the impact of this delay. Do you have a process to bridge this gap?
Again, I think if I've understood the question correctly, what we're trying to do with this second set of prioritization is contact everybody to make sure that your confidence and our confidence match. So in other words, that it is a consensual decision. So we would be hopefully contacting everybody either by letter and if not by means of a telephone conversation over the course of the next few weeks in order to say, look, our prioritization, we think that you perhaps are a P4 or whatever it is. Are you know, and if you're comfortable with that, you can write back to say that's fine, I understand. But if something's changed, then we can have a discussion about that confidence. And so I think if I've understood your question correctly, hopefully that answers. My apologies if I haven't understood it. Would any of the other panelists have a different take on that question?
Okay, thank you. Doesn't look like it. Thank you. Okay, we're going to close the session shortly. Do any of the panelists want to say anything final before we move on to the closing section?
I mean, I think personally, I think the message that I would like to give to the public is that we we have done everything possible to make it as safe as possible for you to go ahead, with your planned surgery. We've carried on doing emergency surgery throughout all of this pandemic, and we're doing everything we can to clear this backlog of planned surgery. And if your condition is worse, if it is changing whilst you're waiting, then please see your GP or contact the department which is treating you, and we can then reassess and hopefully treat matters appropriately. And thank you very much for your forbearance with all of this.
Thank you. Jennifer?
Sorry, I just want to say, just really to say, if you have an appointment for your surgery, whether that's or an outpatient appointment, can I just please encourage you to turn up? We really want to treat you. It really is safe, and it's really important that you get your surgery. So please come.
Thank you. Okay, and as I say, we will make sure that the questions that we haven't been able to answer tonight are answered after the session, and they will be posted on our website. Before we go, we'd really like to hear your views about this event, and in a moment we'll put up 3 quick questions asking for your feedback. These will be anonymous, will not record any personal information with your responses. Your feedback is really important to help us ensure that the way we run these events is helpful. It's important that we run them in the best way possible and cover the topics that interest you. Without your feedback, we could be missing giving some important piece of information that would help you or someone you care about. If you haven't downloaded the Zoom app, you'll not be able to see these questions. But don't worry, you'll have an opportunity to give us your feedback later. And a few final points from me to let you know what's happening next. We'll be posting the webinar on our website in the next few days, and we'll email a link to everyone who registered on the session. Please do share this widely with anyone who you know would find this helpful. With the recording, we'll also give you a link to a short evaluation survey. The survey should only take a few minutes to complete. We ask some optional questions about you, such as your age, gender, and ethnicity. You don't have to answer these, but we'd really like to hear your views on the event. You'll also find a link to the survey on our webpage. So thank you very much, everyone, for joining us this evening. I found it really useful. I hope you have too. If you'd like to leave feedback on any BUCS Health and Social Care Service, please go to our website at www.healthwatchbucks.co.uk, and you can sign up for our newsletter there too. Finally, if this event has raised particular concerns or worried you in any way, please do email us at info@healthwatchbucks.co.uk, and we'll do our best to help. Thank you. And big thank you to our panelists too. Thank you all. Good night. Bye-bye.